So here's a list of the different types of medications that we use to treat these conditions. And we're going to briefly go through each of these and talk a little bit about them. So the first group are the antidepressants. Monoamine oxidase inhibitors, or the MAOIs. These are the oldest antidepressants. They're the very first ones that we had. They're, however, rarely used now. They're not first-line therapy just because of the adverse effects. So you probably will not encounter these in the pharmacy. I don't encounter them that much. But just for completeness, I wanted to mention these here. So, of course, they're used for depression. There's a list there of the generic and the brand. Probably the most commonly used one on there would be the selegiline or the MSAM patch, and maybe phenelzine or Nardil. The mechanism for these, they irreversibly inhibit monoamine oxidase. Well, monoamine oxidase is an enzyme system that breaks down the neurotransmitters that we talked about. So we don't want them to be broken down. So that's why we give an inhibitor, which inhibits the breakdown, so it allows these neurotransmitters to remain in the CNS so we can get the benefits from those. So a lot of these neurotransmitters have to do with our mood, motivation, sleep, wakefulness, attention, pleasure, desire, all of those things which we want. So we want to make sure we have a good balance of those. So in this case, this helps us to have increased concentration of those neurotransmitters. Now, each group of drugs I talk about, we're going to have a list of adverse effects. The ones listed in bold font are the more commonly reported ones. There are many that are not even on this list, but I tried to hit at least the most commonly reported ones and the most serious ones. Orthostatic hypotension, which is low blood pressure upon standing. Headache, fatigue, dizziness, restlessness, GI disturbances, dry mouth, weight gain, sexual dysfunction. So those are commonly reported side effects. The serious one in this case is a hypertensive crisis, and we'll talk about that in just a moment as well. Warnings. This one, along with all antidepressants, carry a black box warning for increased risk of suicidal thinking and behavior in children, adolescents, and young adults. So this is going to be a common theme throughout all the antidepressants. And then the warning, the hypertensive crisis there. This is very serious. It's resulted in death, and it usually occurs within several hours after someone ingests another substance that is contraindicated with this. So certain other medications, certain type of foods, and that's a main reason why these medications are not used. As far as the pharmacogenetic information, this is limited, and we're not going to spend a lot of time on that anyway because these are not really commonly prescribed. Just a couple of drug interactions here. These interact with SSRIs, which we'll talk about those, selective serotonin reuptake inhibitors, and the interaction here is just that SSRIs increase serotonin, MAOIs can increase serotonin. We get too much serotonin, there's something called serotonin syndrome. We'll go over that in just a moment as well. And then with the TCAs, or the tricyclic antidepressants, when you use TCAs in combination with MAOIs, the hypertensive crisis can result. And let me point out, any drug name that's in blue on your screen is a top 200 drug. So those are going to be the commonly prescribed drugs. So I think those are important to mention. In this case, the SSRIs are not recommended to use within 14 days of an MAOI, and the exception to the rule is fluoxetine or Prozac. It's 5 weeks instead of 2 just because Prozac has a long half-life. Okay, SSRIs. These are going to be far more common than MAOIs. They're used for depression, OCD, panic disorder, general anxiety disorder, and social anxiety disorder. There are a lot of off-label uses for these as well, and each particular medication is going to be FDA approved for different conditions. So that's just a general overview what some of them can be used for. I'm going to just read through the names of these just so you can hear them. Citalopram is generic for Celexa, escitalopram, Lexapro, fluoxetine, Prozac, fluvoxamine, Luvox and Luvox CR. Paroxetine is Paxil, Paxil CR, and Pexiva. Sertraline is Zoloft. And as you can see, almost all of them except for Luvox on this list are in the top 200. So I think this is going to be a very applicable class of drugs for you all. The mechanism of action for these is they are selective serotonin reuptake inhibitors. So they inhibit the reabsorption of serotonin. So serotonin is going to come out of the end of this neuron here and get into the synapse. So we want it here so it can bind to the receptor site on the next nerve. And if it's hanging out here, it can be taken back up into the presynaptic nerve. So once it leaves that area, it's no longer available to bind and give us those effects. So if we can block that, then we are able to have increased levels and get the motivation and the pleasure and the desire and wakefulness and all that we want with those neurotransmitters. Adverse effects, most commonly reported anxiety, dizziness, headache, insomnia, sexual dysfunction, nervousness, drowsiness, tremor, sweating, GI disturbances, dry mouth, and weakness. Sexual dysfunction is a big one for this, and also a lot of people have weight gain with some of them as well. Black box warning, again, antidepressants, increased risk of suicidal thinking, and then serotonin syndrome. So serotonin syndrome usually occurs when another substance that increases serotonin is taken with an SSRI, like we talked about the MAOIs. So other substances that increase serotonin are triptans, which are used for migraine headaches like Imitrex or Relpax. Tramadol, pain medication, Ultram, that's one that can increase serotonin, and then SNRIs, which we'll talk about in a moment. So if somebody has serotonin syndrome, it usually presents as the patient will have mental status changes, agitation, confusion, hallucinations. They might be in a coma. They're going to have elevated body temperature, tachycardia or increased heart rate, incoordination, nausea, vomiting, diarrhea, muscle rigidity, and it can result in death. So this is not a very common problem, but it is severe. So this is the format that will be on your all's reports. It's going to list the drug of interest, the pathway that it uses for metabolism, which section of the package insert or the prescribing information you can find information about the pharmacogenetics, and then a brief summary of the information that can be found. So we're just going to briefly go through these and point out the important things here, and this will be a good tool for you all as far as being able to look and see which pathway is involved with which drug. The bolded pathways are the primary pathways, and then the ones that are not bolded are going to be the secondary pathways. The minor pathways or the secondary pathways are still important, even if they're not the primary pathway, just because if there were to be a genetic abnormality with the primary pathway, or we're taking a drug that inhibits the primary pathway, then in that case the secondary pathway is going to be more important. Okay, so citalopram, we have 2C19 and 3A4, and the package insert for citalopram or Celexa does point out that the maximum recommended dose is 20 milligrams per day for patients who are 2C19 poor metabolizers. So if we have a 2C19 poor metabolizer, the recommendation is no more than 20 milligrams a day. And this is in the package insert, and you can find it in the sections listed there, clinical pharmacology, warnings, and so on. Also, citalopram is a relatively weak inhibitor of 2D6. escitalopram or Lexapro, 2C19 and 3A4 again. And in this case, the bottom line for this one is that they have found that a poor metabolizer that takes 20 milligrams of Lexapro resembles an extensive or normal metabolizer that takes 30 milligrams. So all it's saying is a poor metabolizer is going to have increased levels compared to an extensive or normal metabolizer. Also, they believe that it is a 2D6 inhibitor as well. Fluoxetine or Prozac, this one is 2D6 and 2C9. You'll see as we go, the 2D6 is going to be one of our main pathways that we're going to talk about. Fluoxetine is a potent inhibitor of 2D6 and can make individuals with normal 2D6 activity resemble a poor metabolizer. So it's important to know that when we're talking about inhibitors, medications that are inhibitors of pathways, they can make a normal metabolizer resemble a poor metabolizer. So it's kind of unusual and important on this one as well, because you can see that fluoxetine is metabolized by 2D6, and it also is a 2D6 inhibitor. So in this case, it can inhibit its own metabolism, which could lead to increased levels of medication in the body, increased adverse effects, and just like any other inhibitor would do. However, this one inhibits its own metabolism, which kind of makes it a little more complex. It has specific, or goes through some information about in how it inhibits and how we need to watch out with the other drugs that we use with Prozac, but I think we need to make note that it is a potent inhibitor and can inhibit its own metabolism. Fluvoxamine 2D6, this one says caution is indicated in patients known to have reduced levels of 2D6 activity. Fluvoxamine or Luvox is also an inhibitor of several pathways listed there. Paroxetine 2D6, it's a 2D6 inhibitor as well. And sertraline, this one is 2C19, but it is a 2D6 inhibitor. So SSRIs that are 2D6 inhibitors could make extensive metabolizers or normal metabolizers resemble intermediate or poor metabolizers. So let's talk about 2D6. So if we have a 2D6 ultra-rapid metabolizer, they're going to have increased enzyme activity, and which could lead to decreased levels of drug in their body, in their bloodstream. So if a dosage adjustment is necessary, the doctor would probably consider increasing their dose. So if they're an ultra-metabolizer, they're going to have increased enzyme activity, and the doctor might consider a dosage increase. Intermediate metabolizer.
Hey guys, this is Phil. I just wanted to jump in here one thing and add one tidbit. These psychiatric drugs are all, for most part, every and always considered active drug substrates. So the pro-drug, non-pro-drug, these, when interpreting the pharmacogenetics reports, they're keep in mind the psychotropics and all of the psychiatric drugs are considered active drug substrates, meaning they're prescribed in their active form and do not need to be metabolized to be active. And I believe Jessica will go into that a little more, but in interpreting this, the SSRIs in a general statement, that's the reason why. So, all right, turn it back over.
Thank you. Good point. I forgot to mention that. So an intermediate metabolizer is going to have reduced enzyme function, so we could potentially, the physician may potentially consider decreasing the dose. And a poor metabolizer, so this person would have no enzyme activity, so they're going to have increased concentrations of the drug in their blood, and the physician might consider decreasing their dose. And again, this is for non-pro drugs. Just a quick tidbit here. Fluoxetine, it has an active metabolite, but it is still not considered a prodrug because the metabolite, even though it has pharmacological activity, so does the parent compound. So in this case, because those have pharmacologic activity, we don't consider it a prodrug. And also, the half-life of Prozac is extremely long compared to the other medications, and that's why on the MAOIs, when we talked about we would want to avoid certain other antidepressants within a 2-week or 14-day window of the MAOI, the Prozac was actually 5 weeks because of that long half-life. So sometimes Prozac has its own set of rules for drug interactions as far as the time frame we have to wait. Other drug interactions, again, other drugs that increase serotonin, and we already mentioned the fluoxetine, you have to wait the 5-week period. SSRIs that are both inhibitors of and metabolized by 2D6 can inhibit their own metabolism and produce higher than expected plasma concentration. So the two that we talked about are paroxetine and fluoxetine that are both inhibitors and metabolized by 2D6. As far as drug interactions for the SSRIs, we need to look at which pathway the medication is metabolized by. So in this case, we can talk about 2D6 for Prozac and Paxil, and then 3A4 and 2C19 for citalopram and escitalopram. So for substrate to 2D6, we may require lower doses than usually prescribed for the SSRI or the other drug, and that's because the SSRI can inhibit the 2D6 activity, which would cause higher levels of the other drug that we would be administering that would also need 2D6 for metabolism. Inhibitors of 2D6 would require lower doses of SSRIs because they're inhibiting that enzyme function, and I think now it would be good to note that an extensive metabolizer that takes an inhibitor, so a normal metabolizer that is taking an inhibitor would resemble a poor metabolizer. So that inhibitor gets in there, it inhibits the enzyme to make it resemble that of a poor metabolizer. On the same token, an extensive metabolizer that's taking an inducer would resemble an ultra-rapid metabolizer. So I think that's important to note when we talk about drug interactions in your mind. You can be thinking of, to translate this a little beyond to encompass the same meaning for a poor metabolizer for an inhibitor and an ultra-rapid metabolizer for an inducer. I've listed some of the drugs here that are 2D6 inhibitors and substrates. At the end of the presentation, there is a chart that has several medications listed, so I'll just save that for you guys to look over there. So the inhibitors of 3A4, you can have expected increased levels of citalopram and escitalopram, and then inducers you would expect to have decreased levels of citalopram and escitalopram. Okay, SNRIs. So these are our serotonin and norepinephrine reuptake inhibitors. Also indicated for depression, general anxiety disorder, panic disorder, and social anxiety disorder. Examples here: duloxetine, Cymbalta, desvenlafaxine, which is Pristiq, and venlafaxine, which is Effexor or Effexor XR. The mechanism of action: these inhibit the reuptake of serotonin and norepinephrine. These can cause hypertension, dizziness, headache, insomnia, sexual dysfunction, nervousness, drowsiness, tremor, sweating, GI disturbances, dry mouth, blurred vision, weakness, and weight loss. Black box warnings for suicidality again, and also serotonin syndrome because these two increase serotonin. Cymbalta or duloxetine is metabolized through 1A2 and 2D6, and package insert tells us that Cymbalta is an inhibitor of CYP2D6. And venlafaxine or Effexor, this one is kind of unusual. This one has an active metabolite, which we'll refer to as ODV. So it's metabolized primarily by 2D6 into the active metabolite ODV. So because both the parent compound and the active metabolite both have pharmacological activity, we have to look at both aspects of this when we decide what do we do about the dose if we have a poor metabolizer, if we have a 2D6 inhibitor. In this case, when we consider both the parent compound and the active metabolite, we do not have to make any changes. There's no dosage adjustment required when we have a poor metabolizer or when we are administering a CYP2D6 inhibitor. And that's just because they the parent compound and active metabolite kind of balance each other out. So in this case, we do not usually have to dosage adjust. And we also need to note that venlafaxine is an inhibitor of 2D6. So just a couple interesting facts. Desvenlafaxine is actually the active metabolite of venlafaxine. So when we went back there and talked about ODV, the active metabolite of venlafaxine, they were able to isolate that later and make it a drug on its own, which is desvenlafaxine. Venlafaxine, we already mentioned, has the active metabolite, but we do not have to dose adjust because they kind of cancel each other out. And then same thing, the serotonergic drug interactions. Here's a list of some of the CYP drug interactions. So again, we have to look at the medication the medication of interest, figure out which pathway it's metabolized by, and then, for 3A4, we would look at inhibitors, and in this case, 3A4 was the metabolizer of venlafaxine and desvenlafaxine. So inhibitors, azole, antifungals, macrolide antibiotics, and they may increase the levels of venlafaxine and ODV, which we've already discussed about. The 2D6 is the main one there. And in the case of 2D6, we do not require dosage adjustment for venlafaxine. 1A2, duloxetine. This one, the label actually says that potent 1A2 inhibitors should not be administered with duloxetine. So that's why it's important to look at the package insert for specific information, because some of them say not recommended, some of them use words like do not administer. So it's important to check on whatever the drug of interest is to find out specifically what the recommendations are as far as the drug interactions go. Okay, tricyclic antidepressants. These are indicated for depression, insomnia, and OCD. In the list here, amitriptyline was on the top 200, which is generic for Elavil. We have clomipramine, anafranil, desipramine, norpramine, doxepin, Silanor, Sinaclin, imipramine, tofranil, and tofranil PM, and nortriptyline or Pamelor. These inhibit the reuptake of norepinephrine and or serotonin, among other things. These have a lot of other, deal with a lot of other receptors in the body, which kind of lend it to all of the side effects that it has. So they actually can bind with histamine receptors, acetylcholine, many other types of receptors, which we care about those because that's what gives us certain side effects. The two most commonly reported side effects are sedation, which has to do with our histamine receptors, and anticholinergic side effects, which have to do with the acetylcholine receptors. And anticholinergic side effects are our dry mouth, blurred vision, constipation. And the way I remember this is I think of anticholinergic and anti-sludge. So S like Sam, L-U-D like dog, G-E. And you can make the acronym S is salivation, so anti-salivation, so that'll be dry mouth. Anti-lacrimation, which would be dry eyes, which could cause blurry vision. Anti-urination, so that would be our urinary retention. Anti-defecation, that will be our constipation, and anti-gastric emptying, which kind of goes along with the constipation as well. So that's how I remember that, and you can see most of those are the commonly reported ones. But sedation was a big one as well, and then weight gain and headache. You'll notice there arrhythmias, tachycardia, myocardial infarction, or heart attack. Those are not as common, but those are severe. And as far as warnings go, notice the cardiovascular disorders are listed there, along with the increased suicidal risk and the serotonin syndrome. You can see all of these have 2D6 as their major pathway, and all of them also kind of have the same message in the package insert. So 2D6 poor metabolizers have higher than expected plasma concentrations of TCAs when given usual doses. And that would make sense because we know that poor metabolizers have a non-functional enzyme activity, so they're not metabolizing that drug to its inactive form. So therefore, they're going to have higher plasma concentrations at usual doses. Interesting facts, toxicity, overdose. Cardiac and CNS symptoms are usually what appear first. The cardiac or the arrhythmias we mentioned, and then CNS would be convulsions and coma. Death can result from the heart toxicity, and it usually develops rapidly after overdose. And unfortunately, these medications are commonly used in intentional overdoses. Most of the time, however, they're combined with other drugs, alcohol, so forth. Drug interactions, so very similar to the other categories that we've talked about. 2D6 inhibitors, they can make a normal metabolizer resemble a poor metabolizer. A person who is stable on a tricyclic may become abruptly toxic if a 2D6 inhibitor is added to their therapy. So we want to use caution in the co-administration of TCAs with any of the SSRIs, and also from switching from one class to another. And the ones that have 2C19 involvement, we would want to consider the 2C19 inhibitors and substrates as well. Miscellaneous antidepressants, bupropion or Aplenzin, Wellbutrin, Wellbutrin SR, and Excel, mirtazapine, Remeron, and trazodone, Desaril, or Eleptro. These are indicated for depression. Bupropion inhibits the uptake of dopamine and norepinephrine, and mirtazapine and trazodone are not fully understood. They do have some serotonin involvement, but they're not completely understood. Adverse effects of bupropion: agitation, headache, insomnia, GI disturbances, tremor, hypertension, tachycardia or elevated heart rate, confusion, dizziness, warnings, suicidality is the black box warning, and also seizures. Mirtazapine or Remeron: GI disturbances, increased appetite, weight gain, dizziness, dry mouth, and black box warning again, and serotonin syndrome. Mirtazapine is mostly used for, probably more commonly prescribed for sleep than depression, but it's considered an antidepressant. Trazodone: dizziness, confusion, headache, drowsiness, GI disturbances, constipation, confusion, and our same list of warnings. We're going to add in cardiovascular effects on this one. And as far as these go, bupropion is metabolized by 2B6, but it can inhibit 2D6. Mirtazapine mainly is 2D6, and trazodone is 3A4. So the package inserts for these medications talked more about drug interactions involving CYP, and again, want to just check with those package inserts for the specific recommendations for each medication.